So we're back with Dr. Paul Silka, Medical Director of the Emergency Department at Regional Medical Center in San Jose. Dr. Silka, with COVID virus, in addition to supportive therapy, do you have any lessons that you've learned relative to the prescribed supportive therapies, but what's your experience with some of the pharmacological approaches to COVID?
Good question, Dr. Guy. The initial throes, if you will, of the pandemic, what I've referred to as phase one, we felt a little bit helpless. We had all these patients coming in with respiratory symptoms, and we were learning the disease, and we felt as though there was not too much to offer. Of course, there were trials and reports, nothing randomized, but reports of success with hydroxychloroquine and azithromycin, and some of our providers attempted to use that initially, but subsequently we knew that wouldn't be the best choice for our patients as there was limited evidence to that. What we saw as this progressed, though, is into phase 2 and phase 3, as we were seeing more sicker and sicker patients, we saw just a plethora of pathology with each organ being affected. We know about the respiratory disease and the respiratory failure, but we saw disease patterns consistent with myocarditis, pericarditis, acute kidney injury, and even microvascular disease with delayed wound healing and skin finding. So unfortunately, in the emergency department, we tended to be mostly doing our resuscitation and supportive care, but we really had nothing to offer in the first 3 hours other than broad-spectrum antibiotics, working them up and treating them appropriately for sepsis.
You have a lot of experience, obviously, and you've seen a lot relative to trauma, disasters, things come and go in medicine. What's your general gestalt or experience with this overall COVID pandemic? The community response, you've mentioned your staff really leaning into it, but also from an intellectual pursuit.
I will say the providers here at Regional Medical Center have turned into virus geeks, if you will. They're diving into the pathophysiology of this, also the pharmacology. It's led to some pretty good debates about what is available, what might work, what might not. Hydroxychloroquine is obviously the case study in that respect. But I think it's made us become very thoughtful about how we're utilizing resources, not just people's time and equipment, but also pharmacologic resources, and how we're treating patients as they start to get near and into end-of-life issues. Very early on, one of our nurses who had been working in the isolation rooms when we had dedicated negative pressure rooms for our COVID-19 patients, she had spent quite a bit of time in there. She was complaining to me one morning that she had lost smell, the sense of smell, for the last 2 days. And she had a little bit of respiratory complaint. I said, well, do you have a fever? She said, no. I said, are you coughing? She said, no. I said, gosh, that's odd. The next morning, everybody in the world read the piece from Great Britain where the ears, nose, and throat physicians were seeing this influx of patients with loss of smell, and they were all COVID. So I had to call up this nurse retrospectively and said, I'm the worst clinician. I missed your COVID-19 symptoms. Subsequently, she was out for 2 weeks. No respiratory complaints, never had a fever. She's recovered about 90% of her sense of smell to date. That was about 4 weeks ago now.
That's a great story. We've been talking to Dr. Paul Silka, who is the Emergency Department Medical Director at Regional Medical Center in San Jose, California. Dr. Silka, thank you for taking the time. My name is Jeff Guy from HCA. Thank you.
Thanks, Dr. Guy.